All right. Our next speaker is Dr. Eric van Staalduinen. He is a clinical assistant professor of radiology at Stanford University and a board-certified neuroradiologist. He specializes in diagnostic neuroimaging with a research focus that bridges cognitive therapy, clinical neuroscience, and computational modeling. His work integrates advanced imaging and AI, including deep learning tools for stroke detection and predictive modeling of outcomes. He also investigates biomarkers of neurodegeneration, such as olfactory changes in preclinical Alzheimer's and Parkinson's disease, and cerebrospinal fluid imaging anatomy. He contributes to interdisciplinary efforts that use neuroimaging to uncover brain circuit dysfunctions underlying psychiatric illness, and is a key member of Stanford's Neuroimaging and Neurointervention group. He plays a vital role in collaborative case conferences that bring radiologists and psychiatrists together to advance precision diagnostics in psychiatry. So join me in welcoming.
Good afternoon, everyone. I'd like to start by thanking the organizing committee for inviting me to speak today. I have no disclosures to report. I'd like to share how we're advancing precision mental health with neuroimaging at Stanford. And I'll try to illustrate this with a case-based approach. So we're going to start with a patient in their 60s who was referred to our precision mental health clinic for refractory depression. They endorsed depressed mood, inability to maintain focus on tasks, memory difficulties, brain fog, little motivation, and frequent crying spells. They worry daily about loved ones dying and report various physical complaints too, such as hot and cold sweats, shakiness, rapid heartbeat, lightheadedness, speech difficulties, and even hand cramping. They've previously trialed and failed numerous antidepressant medications. As part of our workup, we often obtain brain imaging with structural and functional MRI. So here we see some coronal T1-weighted MR images of our patient. I've annotated several regions of interest for brain circuitry mapping. You'll see here that we have normal brain volume. We have normal gray-white matter differentiation. We don't see underlying white matter disease. There's no masses or other obvious reason for this patient's symptoms. Overall, an unremarkable and kind of normal brain MRI. And so structural brain abnormalities do occur in patients with depression and anxiety. Some have described increased size of the lateral ventricles and decreased volume of basal ganglia, thalami, hippocampi, and prefrontal and orbital frontal regions of frontal lobes. Some have also described decreased volume in left middle frontal gyrus, which can identify a subset of those patients who will not remit to antidepressant medications. And while these imaging findings are helpful and point to an anatomic association for depression, you can see how challenging it is to actually implement these findings in the clinical setting and use them in a meaningful way. And so structural brain MRI remains largely unrevealing and non-contributory in the clinical setting for those with depression. As this is troublesome and frustrating from a clinical perspective, because while we know something is clearly wrong in the brain, we can't see something that we can target and go after as we would in other situations, like this patient with a stroke, where there's a very clear lesion, or this patient with a brain tumor. These patients have clear lesions that we can attribute symptoms to and target. Patients with depression and anxiety have relatively normal structural imaging and remain non-lesional from a structural conventional imaging perspective. And this begs the question that we need another tool, something else that can help us treat them and offer them better therapies. And this is where functional brain imaging comes in. So this offers unique insights for understanding the neuroanatomical basis of depression and anxiety and other mental health disorders. We have diffusion tensor imaging, which can evaluate structural connectivity, and functional MRI with resting state and task-evoked methods. And these help to evaluate neural circuit architecture with activity and connectivity in ways that you can't otherwise see. And this opens up a whole new world for translating these mechanisms to the clinic for the radiologists and psychiatrists as we look to use these to evaluate for this basis of disease. Here we see conventional fMRI and DTI examples. So this is an example of the output that we are used to seeing in the clinic. We'd often do this for brain mapping, for language lateralization. So on the screen left, you'll see a patient who has left lateralization of language function. And on screen right, you see DTI imaging, where we have the streamlines of eloquent white matter tracks overlaid and adjacent to this very clear brain tumor. And so you're able to see where the problems are. And this is the type of output that we often have. Here's an example of the paradigms we use in order to generate this data for language mapping. The visual response naming paradigm asks the patient to read this prompt and think about what it is. The object naming paradigm asks one to look at this picture and think about what it is and something to do with it. And in this way, they're able to generate where the blood signal is going and identify where the language centers are. And so this is kind of different than in the psychiatric setting and the mapping of brain circuits in the setting of depression. And so one way of processing this data and generating this information is with the Stanford Siri image processing system described by Dr. Leanne Williams. And so it probes 6 unique brain circuits and consists of a 3D high resolution T1 weighted sequence. And we do 2 paradigms or tasks. The facial expressions of emotion task, where we evaluate positive and negative affect circuits, and the go, no-go task, where we evaluate the cognitive control circuit. And then measures of default mode, attention, and salient circuits are derived from this task data. Here you see an example of a stimulus for our facial expressions of emotion task. And here we see some of the outputs in the brain circuits evaluated with this type of stimulus. Here you see an example of the go, no-go task and the brain processing required to generate this type of information for the cognitive control circuit. Here you have a short table comparing the clinical protocols for our brain mapping. So in those with depression and anxiety, we run these three paradigms, and each one is about 5 minutes. This is in comparison to the language lateralization, where each paradigm is about 4 minutes, so slightly longer, but we are able to integrate this into the clinic and get real-time data. So our patient underwent brain circuit mapping for precision mental health assessment, in addition to a battery of other cognitive tests. Here you see an example of some of the output measures when we do this type of testing. And so we have an overview of each individual brain circuit, where the regions of interest are and what those circuits are showing and how they're important. Here we see a summary map of our patient's individual scores. And we see individual scores per circuit, and this gives you an idea of where problems may be. And if you haven't seen these before, that's okay. The scores range from 1 to 10. And a healthy range is considered 3.5 to 7.5. And so if you have scores within that range, they're considered normal or healthy. If you have scores outside of that range, either too high or too low, these are considered abnormal. And these are in comparison to those with depression and anxiety versus healthy volunteers. And so you'll notice that in our subject, we see dysfunction in the salience circuit. We see a slightly decreased brain circuit score. As we probe further into the individual brain circuits, you'll see here we have an example of the default mode, and here we're looking at connectivity throughout this circuit, and you'll see that it is generally falling in the healthy range. Everything is looking good. When you look at the salient circuit, we'll see that things are a little bit on the lower side, with the average score being 3.4, and this was indicated in the overall summary map. When we look at the attention circuit, you'll see that the scores are in general along the low normal range, but there is one area of decreased connectivity between the mesial superior prefrontal cortex and the right lateral prefrontal cortex that is outside the range of normal. When you look at the negative affect circuit in response to a sad stimulus, you'll see that the scores are kind of varied, and the overall average score is within the healthy range, but there is one area of markedly decreased activity in the pregenual anterior cingulate cortex that stands out. When you look at the negative affect circuit in response to conscious and non-conscious threats, you'll see that these scores are generally within the healthy range, and we're not seeing any problems there. And likewise, when you look at the positive affect and cognitive control circuits, we're seeing that scores are again falling in the healthy range. So how do we best interpret this data? So we found that at Stanford, we have developed a collaborative multidisciplinary approach between psychiatry and radiology in order to interpret all of this data. And we call our meetings connectivity conferences, and they're kind of akin to a tumor board. Together, we review all relevant patient data and information, and we generate a personalized assessment and treatment recommendation for them. Together, we look at and review and correlate their self-described symptoms and symptom score reports. Here's an example of some symptom reports that we have. We look at cognitive assessments and various measures of cognitive testing. So this is part of the total brain package where we're looking at different ways of thinking and functioning. We look at prior treatments and treatment failures. We even look at pharmacogenomics and try to probe as to why maybe somebody didn't respond to a treatment, if it was dose related or if that was a factor. And of course, we look at the imaging data, both structural and functional MRI. And so our patient reported moderate symptoms of depression, anxiety, and trauma-related experiences with overall low satisfaction of life. And the most severe and frequent symptoms were fatigue, cognitive problems, and anxious ruminations. Here we see an example of their reported symptoms. They also reported these episodic neurologic symptoms, including hot and cold sweats, shakiness, rapid heartbeat, lightheadedness, speech difficulties, and hand cramping. Here we see an example of the symptoms that they reported. And so in terms of interpreting this data, the structural imaging was helpful. It was negative for signs of neurodegeneration, negative for signs of small vessel disease or demyelinating process or mass. That helped us in this case because there were neurologic symptoms at play. The fMRI revealed salient circuit hypoconnectivity, some attention circuit hypoconnectivity, and low activity in the pregenual anterior cingulate region. It also demonstrated healthy activity in the default mode, positive affect, and cognitive control circuits. And so we concluded that this patient had salience and attention circuit dysfunction characterized by hypoconnectivity. And we also suspected that they had a functional neurological disorder to account for some of their symptoms. We then recommended a trial of atomoxetine as it can increase attention circuit connectivity and has been shown to improve attention in adults with ADHD. And it can also target ruminative worries and physical symptoms of anxiety. We also considered bupropion as a backup in case of treatment failure, as it can target fatigue and attention. I'll briefly discuss a companion case. And this is a patient in their 20s with moderate to severe symptoms of depression and anxiety. These are most notable for anxious ruminations, suicidal thoughts, anhedonia, and multiple failed antidepressant medications. Here we have a screenshot of their brain circuit scores for the default mode and frontoparietal attention networks. And you'll notice that these are characterized by increased connectivity throughout the default mode diffusely and increased connectivity throughout the frontoparietal attention network in the mesial superior prefrontal cortex and the left lateral prefrontal cortex. We concluded that they were characterized by default mode network and attention circuit dysfunction with hyperconnectivity, and we recommended TMS for this patient. I won't discuss TMS any further, as Dr. Nolan Williams, who's an expert in the field, will be talking about it next, and so you'll look forward to hearing that. I'll close by highlighting future directions and opportunities for precision mental health. First, I hope I've illustrated for you a clinical pathway forward for precision mental health using neuroimaging at the individual level. And we're optimistic that this approach can save patients from prolonged suffering and cost owing to medication trial and error periods and help to guide them to directed therapy the first time. Second, we're really excited about this opportunity between radiology and psychiatry as we look to transform our understanding of and approach to mental health with the chance to shift the paradigm of classifying these as collections of symptoms to individualized measures of brain circuit dysfunction. And so as a neuroradiologist, I see a ton of opportunity and potential here for education, collaboration, and the development of future biomarkers to help guide therapy for these patients. This won't happen without continued support of the healthcare system. And if we do go forward with relying more on neuroimaging for these assessments, we're going to need to refine clinical workflows, improve access to MRI, and greatly educate the public, the patients, the clinicians, and everyone as to what this means. And so in closing, I hope that our model of practice can serve as an example to others as we help to usher in this era of precision mental health. Thank you.